Okay, welcome everybody. Thank you for coming. We are full on in our series on the 5 new things. You may have noticed, Jenna, that we now have CME, actually, for this. And we are really excited to finally have the long expected Dr. Jalal Andre talking to us about neuroimaging. Jalal hails from Stanford, where he did his neuroradiology training. He's been here long enough that I haven't heard him pull the where I trained card very much anymore. He's been here 5 years. He's assistant professor, UW assistant professor in neuroradiology and director of MRI. I think he trained in MRI. He tells us a lot about MRI. His research interest is in MRI, and I think he's going to talk about MRI today. Thanks.
Oh, it's possible. Well, thank you. And the truth is the reason why I didn't show up a couple weeks ago is because I needed the extra 2 weeks to put together the talk. So let me see what I have in store for you guys today. So first thing is I thought I would tell you about 5 new things in neuroimaging, and believe it or not, I will focus primarily on MRI, but not exclusively. And can everybody hear me? Okay, excellent, good. Okay. So I don't really have any relevant disclosures other than I receive some grant funding from the following institutions and or sources. So I thought I'd focus on 5 main topics. One would be motion, gadolinium deposition in imaging solutions, dual energy CT, clearly not MRI, and 5-minute MRI, and then something called demodulation. So the first one I'll talk about is motion. And when we first started looking at, or when I first came here, I kind of wondered, is motion a problem? And I saw sequences, and this is actually a real sequence that was scanned at Harborview, and I realized, wow, and some people do move in the scanner. And I'm convinced that actually what's going on is the person's doing that over there in the red arrow. That's what they're really trying to do. But interestingly, the prevalence of motion artifacts is actually pretty poorly documented in the literature. And so we thought it would be interesting to look at what is the frequency and or prevalence of motion artifacts in clinical MRI. And so the first thing to think about is that not all motion looks the same in MRI, and it really is dependent on readout and a couple other things. No, it's perfect. It's good. So it doesn't quite look the same. It doesn't manifest the same. And in fact, here, for example, we have DWI with an EPI readout, echoplanar imaging readout. And we see what we would rate as minimal, and then the second one is mild motion. And it actually manifests as blurring of the image, as you can see by the arrow here. And that's different from what we traditionally see, which are these kind of ring artifacts, or some people call them ghosting artifacts, and that was what we saw in the prior series. But the reason why I mention this is because motion, although it may seem, I guess unpleasant to us in terms of imaging, actually could potentially have diagnostic consequences, as is illustrated by this case of a patient who had acute onset of altered mental status and was sent in by the referring doctor for an MRI. This was actually a study or an MRI that was obtained here at the University of Washington, and this is a patient who was actually, the sequence is interpreted by somebody I think we all love and respect, and who of course remain anonymous. But this was interpreted as some motion degradation, but otherwise within normal limits. And fortunately, because the patient's symptoms persisted for another 6 weeks, the referring doctor sent them back in and just wasn't convinced that this was a negative exam. And so the exam was repeated with 20 milliliters of identical gadolinium-based contrast agent, in again 6 weeks apart from that initial study. And this is their repeat examination when they were better able to tolerate their exam. And although I don't know if this projects terribly well, I hope you can see that there are multifocal. In fact, there's probably about 100 intracranial metastases. So all these enhancing lesions just riddled throughout the brain. And in this case, this represented, fortunately, only a delay in diagnosis by about 6 weeks. But again, I think it really illustrates that motion, while unpleasant to look at, can also have some significant diagnostic consequences. And so because of this, we decided to look at the degree of subjective motion in patients. And we had a clinical metric in addition to our radiographic metric. And our radiographic metric is kind of illustrated by these 4 examples up top here, where you have essentially a minimal, mild, moderate, and severe motion. But more importantly, the key thing that differentiated mild, which we said could even be unpleasant artifacts, artifacts that we don't really feel, we're not too excited about. The key thing that differentiated that from moderate was that moderate, we felt that had the potential to reach the patient and could potentially alter the actual interpretation of the exam. And then, of course, severe was one in which the actual underlying anatomy was distorted enough that we couldn't see it. And so just to really quickly go through this, we ended up looking at about 192 exams in total. Many of them were of the neuro axis. And in those exams, so we looked at a 1-week period of exams, one full calendar week. We found 68 repeat sequences, or essentially about affecting nearly 20% of MRI exams performed during that one calendar week at Harborview. And just to illustrate the breakdown that we found, so if we looked at motion artifacts across all MRI exams, we found that there was a relative distribution of none versus mild versus, I'm sorry, minimal, mild, yellow is moderate, and then red is severe motion. And you can see in this case that we have about 5% that are severely motion degraded across all exams. When we start breaking that down into exams of just the neuro axis, we see that the relative distribution doesn't change so much. We again see approximately 5 versus 12% here for moderate. And then if we look at just the brain, we see that the number of severe motion degraded exams drops slightly, but maybe not so significantly. What was more interesting to us was that if the patient was an outpatient during their imaging session, that they had a significantly reduced rate of moderate and severely motion degraded exams as opposed to those who were performed as an inpatient or an ED patient. And of course that might make sense because they're more agitated, they're less able to cooperate, they're in pain. But you can notice that there's a significant disparity between these two. So rather than looking at the actual anatomic region that was imaged as a predictor of whether or not motion was going to occur, it seemed that the patient disposition was more likely to be a predictor of that. And these results weren't so different from some results that have been reported in the literature. This is actually a study that was done in 1,200 pediatric patients looking at DTI, in which they used motion registration to evaluate what the degree of motion was on a per image basis. And this is basically their, just the degree of translational motion, as you can see here, 0 to 1 millimeters and up to 10 millimeters here. So not so disparate from the results that we obtained. And then we tried to attach a financial, I guess a cost, essentially, the cost estimate of what the financial value of this would be. Not for any other reason other than just to really look at efficiency of the scanner and whether or not we could, are we efficiently looking at images. And because when we have to repeat sequences, of course, then that delays future studies from being done. And of course, if we have patients waiting for exams, whether acute or outpatient imaging studies, it simply delays their examination, and of course they get frustrated. So in part for patient satisfaction, also for patient safety, and then of course resource utilization, we looked at this. And this was difficult to quantify. I will spare the details, but basically what we did is we assumed that all exams were essentially a non-contrast MRI exam of the brain, and then we applied that for all exams. And whether or not that's fair or not, of course, I will leave that up to you. But the reason why we did this is that just made this analysis very simple. And so when we did that, we found out that there's about $600 per hour can be lost on the scanner per motion. So and that extrapolated over 1 year. If we take that 1 week time period and we extrapolate over a year, we look at something that's closer to about $100,000 or more per year per scanner at this one institution. And that was just looking at the exams, the sequences that were repeated. That wasn't even looking at the exams that should have been repeated, meaning those that were moderately or severely motion degraded. Yeah.
What percentage of the funds generated by the MRI scan for the year does that represent? I mean, that's probably like 0.01% of.
That I don't have the answer to that. That's a great question. I'm sorry, the question was for those who are on the web was what percentage of the total cost is that for the MRI scanner for the year? And I don't know that. That's a good question. I think the point is it's not something that's insignificant, meaning that if you look at, so we have 3 scanners at Harborview, so this is at least $300,000 or more per year, so it's not an insignificant amount. But the reason why I wanted to mention this is because, I wanted to tell you this story, is because this is not a problem that doesn't have solutions. It's simply an observation that we made. We thought this was important, and we tried to quantify it as best we could. 2 things I'll tell you that we feel that the prevalence of repeat sequences is somewhere between 17% and approaching 20%. We actually looked at 2 different weeks of time points here over the course of about 8 months. And then this was recently published in JACR if you want to know more details about the actual study. But the reason, again, why I mention is because we don't have to tolerate sequences or images that look like this. And I know that these are the most severe cases. In fact, there was a nice review article by McLaren and colleagues in MRM in 2013 that actually looked at some of these, and I should say there must be at least 30 different techniques that are available. Some of them are navigator records that are incorporated into the sequences. Some of them are optical tracking devices. I don't have time to go into all of them, but the real reason why I wanted to mention the motion, it was really to talk about some of these solutions. And this is one of these solutions that that I found was something that I worked with before in the past, and this is a motion-corrected neuroimaging protocol. And this is simply another case that illustrates a very similar example. This is somebody that was scanned in Australia and had this study where you can see that there's motion degradation. Whether or not it's moderate or severe, I would say this borderline, borderline severe because of the distortion of the underlying anatomy. Fortunately, somebody was literally walking by as they were going to put the final read in and said, absolutely not, we're going to bring them back tomorrow. They brought them back the next day, and just like we saw in that prior study, that there are areas of enhancement, and this patient was found to have about 30 little foci of enhancement consistent with intracranial metastases. Again, just illustrating that same thing that motion does sometimes reach the patient. Okay, so in this case, what is done, and essentially, rather than use these navigator echoes that have to then be built into each sequence, one of the things that can be done is basically adaptive motion correction using optical tracking. What is a lot of the details here are provided in this paper here, but this is essentially we measure the patient motion with minimum time lag, and then this essentially the motion is evaluated, and then that's sent back to the scanner, and the scanner is adjusted in real time. And so here's just an example of the setup. So here we have the MRI scanner. There's a digital camera that's mounted to the head coil. Essentially, most of these studies were done in the brain. This information is sent to a motion tracking computer or using motion tracking software, and then the motion parameters are evaluated. This information is then sent back to to update the scanner geometry on a relatively live or prospective basis. And this uses this self-encoded marker with a small camera mounted to the head coil, as I mentioned here. So this is essentially a picture of the setup. And the camera measures motion independently of the sequence so that the scanner is essentially allowed to operate. I mean, if you think about a computer, the more you ask the computer to do, the less efficient it's going to perform. So in this case, we allow the scanner to do what it does best, which is imaging, while the motion tracking software and the camera itself do something that's independent of that. And so I just want to show you some examples in human subjects. These were 8 volunteers that performed pre-specified motion maneuvers, and essentially we asked them to do, coughing, falling asleep, nodding, and trying to simulate no motion. The sequence updates were built into several sequences, so there's 11 in total here. And then these are the examples in volunteers, and this is what I really wanted to show you. So this is basically a 3D T1 weighted image. This is with motion and then without motion. Essentially, once motion correction has been performed. So this is, again, prospectively done so that the scanner is updated. Here is, again, no motion, and then with motion correction applied. This is a sagittal T1 weighted image. Here's a 3D time of flight circle of Willis, and this is what it looks like with motion correction. Essentially, again, no motion correction with motion correction in a different subject. Here is yet another example on a GRE sequence without motion and with motion correction on. A T2 weighted sequence. So just going through and showing how these can be used. Here's again another subject. This is without motion correction applied and then with motion correction. And this is essentially the equivalent of an SWI sequence on the GE scanner. That's with motion correction. So I think it's, the images speak for themselves. Up top we have, or sorry, below here we have a flare and a DTI that was performed without the motion correction, and then of course above is with motion correction. And then this was also done in patients, and what's nice about this is you can actually essentially evaluate the degree of translation and rotation that the patient experiences in 6 planes while this is being performed, and so you can see what happens in an awake person as opposed to somebody who's imaged under general anesthesia. And I think even when they're imaged under general anesthesia, where we think there's relatively no motion, you see that there's a little blip here suggesting that there is some motion that occurs even when they're under GA. And this was a relatively cooperative 16-year-old who tried to remain absolutely motionless. And you can see that even when they try and remain motionless, that they still have some of those ring artifacts that we said here. And then, of course, when the motion tracking correction software is on, that clears up the image. This is again a 69-year-old female who essentially had, this was again a real patient. These are their tracings of their rotation and translation in real time, and then this is without on the left and then with on the right motion correction. Same thing here, 75-year-old with Parkinson's disease. This is a pre-op DBS protocol, and of course another one with Parkinson's disease, and of course these people are more likely to move. So I think you get the point. Here's somebody who has a circle of Willis evaluated again without and with, without and with. Here's arterial spin labeling, without, and then there's with. I think you guys are used to more seeing images that look like this at Harborview. Okay, so in conclusion, I just wanted to show that this adaptive motion or optical motion correction can be integrated into a workflow and can obviously improve the quality of images in a clinical population. It remains to be seen whether or not it can improve the quality of the images of the type of motion that I showed before that we see at Harborview, which I think it really is pretty severe in some cases. But I think one of the things that we notice is that even when there's severe motion, if we can mitigate that motion or downplay it into the kind of mild, essentially quality, that's still readable. Meaning, if it doesn't affect the patient, it doesn't affect our reads, then that's I think that then we're pretty satisfied with that. Okay. Finally, I just wanted to finish this up with just talking about something called markerless tracking. I don't have enough time to go. Absolutely. Either one. Happy to answer a question now.
So in the absence of that, I think it's really important that the limitation of movement gets conveyed to the non-initiated, because there have been plenty of situations, and I think Eric, you present one as a QI, where people read the final report and they say it's normal. Right. So I think you guys need to have a criterion for repeating that needs to be really clear in the summary of limitations of this.
Right. So for those of you who are watching on the web, that the point was made that we should include the degree of motion or extent of motion within our reports and really talk about whether or not it's diagnostic in quality. Something that I certainly try and do. I think that others who are involved in this project, we now that we're aware of this problem, we try and do this. But I think the relative paucity of data in the literature, I think, also is a testament to the fact that most radiologists feel confident, whether or not it's the right thing to do, feel relatively confident reading through motion. And I think I've shown several examples where that's probably not a good idea. And I think as this information is, better disseminated, that people start to take a look at that a little more in detail.
Severe, don't your texts automatically repeat sequences on the fly?
That's absolutely, and a lot of these examples that I showed were the repeats. That's the best they can do. Sometimes the best they can do is some of what I showed you. I think, yeah, and these are great observations. Anyway, I just wanted to mention that, that there is, and I would say this is at least 10 to 15 years down the road from now, but something that I saw recently at a conference was using essentially laser optical tracking, and this was without the use of a marker, which I think is fantastic, but again, I think it's about 10 years away. But I just wanted to throw it out there. There are several techniques that are available. I think, again, the goal is to just bring down severe and moderate into the minimal and mild range, and then I think we wouldn't have a true risk to the patient. Okay. So next thing I wanted to quickly talk about is gadolinium deposition in imaging solutions, and I won't spend too much time talking about gadolinium deposition. I want to make two key points here. One is that there have been a few papers now that have mentioned this, and that we see that in patients who have serial contrast enhanced MRI examinations, that there seems to be deposition of gadolinium within various structures within the brain. More importantly, there are also several papers that are starting to come out and have been released in the last few months that show that it primarily seems to be at this point more of the linear agents that were used, and some of those older agents, and the macrocyclic agents or the newer agents seem to have a lot less gadolinium deposition. The significance of this, I think, is unclear at this point, meaning that gadolinium leaching into the brain has unknown consequences. It's unclear if there's any, but I think the fact that we observe that it is leaching into the brain is, I think, of at least note and of potential concern. And it's not, this isn't to say that I started working with arterial spin labeling with this in mind. It happens to be convenient, but I don't want to also, I don't want to emphasize the fact that, that or make, I guess, give the perception that gadolinium is inherently wrong in and of itself. But I do think that there are some nice solutions that can be done with imaging without gadolinium. And rather than talk about ASL in a lot of details in terms of when it can be used, I just want to tell you a little bit about some of the things that we've been doing in terms of improving the quality of ASL. And I shouldn't say just we here, but also at other institutions. This is what you guys see on PACS. This is the arterial spin labeling sequence that you see on PACS. This is a 40-year-old who had 3 sequential ASL sequences performed at the same imaging session. And I just wanted to illustrate that this is a Polster, the product ASL that we currently have on PACS at Harborview, and that these are 2 experimental and/or work-in-progress sequences that have been developed, and this one here is going to be incorporated into a scanner upgrade around the the turn of the year. So in 2016, we should have this newer variant. But I think you can see just in terms of signal deposition, or essentially signal inhomogeneity, that this is certainly an improved sequence here, and I'll talk a little bit about this in a bit. Because of the kind of disparity in sequence or readout quality and also labeling efficiency, one of the things we looked at, Jim Pipe down at the Barrow Institute is an MR physicist. He was kind enough to share some of his images or his data with me. And these are actually the same patient acquired with 5 different readouts. So the labeling technique is the same. It's basically the radio frequency pulses are deposited in the neck, and then we take a picture of the brain later, and then we can quantify cerebral blood flow based on that. And if you notice, that there are some subtle differences between the two in terms of gray-white differentiation and also maybe inhomogeneity of signal. Like, for example, in this case, this 3D grace has more signal posteriorly than it does anteriorly. What we did is we did some statistical analysis of this, and we looked at the mean standard deviation and then the coefficient of variance of these. And there were 7 subjects that were scanned with 5 different readouts. And so we have essentially what we've done is we've morphed all of their brains, or essentially all their ASL sequences, into the same atlas space, and then performed the statistical analysis on those same brains. And what we see, though, is that as you can see, the mean of the signal is very different depending on the different readout that we perform, and that the distribution of that signal, again, as I mentioned before, this grace readout, for example, seems to have some site AP inhomogeneous signal deposition. And that there are other sequences that are the readout methods that may be better than others. And I think this is a work in progress, so I just wanted to put it out there, let you know that we're working on it, and that at some point, I hope soon, we'll be able to incorporate this into clinical imaging here at the University of Washington. At Harborview, we have we have another solution in mind. So I wanted to also just talk about ASL as a quantitative method that allows inter-subject comparison and also global changes in physiology. Just briefly touch on this. This is actually a slide that was sent to me by Swati Lewandowski. Is that correct? Sorry, and Swati's sitting right here in the back, and she's actually a new member of Tom Grabowski's lab, and I'm very excited about working with her. But this is essentially data that we collected on the scanner, and she was kind enough to translate this into color ASL maps for us. And so, again, just illustrating that this is a quantitative technique. And without GAD, you essentially spend 5 minutes, 6 minutes of scan time, and you end up with some nice color images. Potentially, I think our goal is ultimately to put this as a pipeline from the scanner so that it just goes directly to packs like this. Another solution that may be possible is where we take this raw data and we then perform CBF correction, or essentially we generate CBF images. And we generate, essentially we can compare that to a normative control database then, where we can generate z-score maps. And essentially that's what these are, where the red color here is represents 4 standard deviations away from. And so rather than getting CBF, which we obtain here as the raw data, you could look at this as CBF and as a stack of images. Or you could look at this as a set of projections, where those projections are essentially a z-score from or essentially standard deviation away from the mean on a voxel by voxel basis. And I'll just point out one quick thing here, that that the radiologic convention has been reversed. This is a nuclear medicine technique that I adopted this from. But essentially we can do this, and then of course we've done this on a couple different patients just for proof of principle. These are either resection cavities, old infarcts, and/or patients with Moyamoya disease. So these are just some examples of what we can do with this. So either way, I think this is important as a quantitative imaging biomarker, and potentially could be used across a wide variety of pathologies. I wanted to quickly talk about something we're doing at Harborview, and as a prelude to that, essentially the way ASL works is we have a labeling period, and then we acquire an image after that. And essentially the time between our labeling period and when we acquire that image is called the post-label delay. And what we're really doing is we're trying to decide when that label is going to arrive at the target tissue in the brain, so that we can then take an image of the brain. Because we really want that label that we deposited in the neck to arrive at the tissue, exchange with the water of the tissue, and so then we can say that the label has already arrived in the tissue. So we're really talking about cerebral blood flow. And we assume, of course, in that there's basically autonomic regulation and metabolism drives that blood flow. And of course, in pathology, that may not be the case. But I wanted to show that when you extend, when you use longer delays, you end up with better quantification of your CBF. This is a case of a patient with bilateral Moyamoya disease, Whereas if you use a post-label delay of 1 second, that you essentially, it looks like they have very aberrant and abnormal blood flow in the bilateral MCA distribution. And that's because we've imaged faster than we allowed the label to reach the target tissue. But as we extend our post-label delay out to maybe even 2 seconds, you can see that that starts to fill in pretty well. By 2.5 seconds, it's maybe not even so obvious. And then by 3 seconds, I don't know that anybody could perceive a difference between the different the vascular territories. The key thing, though, is, of course, we lose NR as we do this, as we extend our delays out further. And then, of course, the imaging time. And this is something that was provided as a courtesy from David Alsop on the East Coast. And this was actually based on work that had been done in essentially 2008. So our techniques are a little bit better now, a little faster. So it doesn't require 8 minutes of scan time to achieve a 3-second delay. But what we're doing at Harborview on a research basis is we're actually looking at multiple post-label delays. So it's called a multi-delay ASL sequence. And so we're essentially just acquiring multiple time points here. And then we're using modeling to reconstruct or essentially look at where that CBF is on a voxel by voxel basis, depending on where or when the label arrives to the target tissue. And so here's an example of, on the top here of the screen, this is actually a normal volunteer. This is what their blood flow looks like. This is always on a scale of 0 to 100. So 100 is yellow, 0 is black. And below that is somebody who has severe vasospasm. And so this is what we're applying this to on a clinical basis. And this is actually being done in conjunction with the neurosurgeons and the neuro IR people. It's actually a pretty large project, and I'm very thankful for all the input and help that they've provided. I wanted to mention what we've done is we've essentially, we're collecting patients en route to an emergent diagnostic angiogram, and we're routing them to an MRI for about 10 minutes. And so they do a 10-minute MRI on their way to diagnostic cerebral angiogram for possible endovascular therapy for their vasospasm. And this is an illustrative case where this is actually somebody who had normal evaluation of essentially normal velocities by TCD analysis in both the A1 and M1 segment on the left side here. But of course, their M2 segments are literally sausage-shaped. And you can see how essentially they've got multiple wedge-shaped areas of hypoperfusion. And this is someone here, another example where we felt that ASL was, and this was actually the interventionalists themselves interpreted the ASL sequences and found out that there was an area of hypoperfusion, relative hypoperfusion in the right MCA territory that was less, less conspicuous in the DSA exam. And so just some important highlights here. I want to mention that one, we've looked at 10 patients so far, that's actually a total of 45 vascular territories. Of those, we found that, so when the neurointerventionalists looked at the DSA and then commented on treatment and then went back at ASL, they agreed, although they did this independently, they agreed that that ASL prospectively would have changed management in 7 to 8 of 10 of these patients. And that they agreed, again, independently evaluating these patients, that 3 of them would have not needed the diagnostic angiogram. So I think the importance is that if you obtain perfusion imaging essentially in these vasospasm patients, you could potentially obviate the need for diagnostic cerebral angiogram, an invasive procedure in those patients that, of course, save hospital resources or conserve hospital resources. This is something that we just submitted actually a couple weekends ago, so we're keeping our fingers crossed. Wanted to quickly mention a couple other things that we can do with arterial spin labeling. One is change the labeling plane, and this was something that was done in 2004, where we changed the labeling plane. We can evaluate a portion of the perfusion in that territory. This is work by a friend of mine in Europe who evaluated the posterior, essentially perfusion imaging using essentially the posterior fossa, just by virtue of angling these slabs to select different vessels and then color coding these vessels. Fortunately, now we can actually do this, or I shouldn't say we, but it's possible to actually independently or individually label these vessels without angling the slabs and actually do it on a frequency basis. But just to show these nice images. And this is probably one of my favorite things. This is one of the newest techniques that I've seen. And this is arterial spin labeling using a look locker readout. And you essentially have what looks like an MR angiogram, only it's in real time. This is about a 5-minute sequence. Unfortunately, not yet commercially available, but I think it has some nice implications here. And then I also wanted to mention another technique that, again, is not dependent on gadolinium, which is something that's been developed, again, by Swati in the back here, which is I-vaso, or essentially inflow vascular space occupancy. And this is the only technique that's currently that we know of where you can measure cerebral blood volume without the use of gadolinium. Otherwise, it's dependent on gadolinium or some kind of intravascular contrast agent to do this. So we're very excited about potentially implementing this and looking at what this can do, and potentially in the context of vasospasm. I think that would be interesting. Okay, finally I want to talk about dual energy CT, and this is also, again, something that we've just acquired at Harborview, and we're very excited about it. I also want to mention that several other centers have obtained this, this technique or technology up and down the West Coast and certainly on the East Coast as well. The nice thing about the dual energy CT is basically what you are able to do is, well, essentially without increasing dose to the patient, we can actually generate a lot of simulated data, or essentially, you know, we can mathematically model some of this data based on the based on acquiring two different energy levels for CT. Okay, so this, and my interest in this began when I first got here. We a group of us got together and we decided that we wanted to see if iterative reconstruction on CT could improve the detection of recurrent aneurysms in the setting of coils or aneurysm clip placement. And so because this was new at the time, we noticed that, you know, there's significant artifact that arises, especially on CTA, and so you've got contrast on board, and of course there's a lot of streak or metal artifact from coils and also clips as well, making evaluation for recurrent or residual aneurysms right next to those clips or coils very difficult. And we were pretty frustrated with this. One solution, of course, and this is the current solution, is to use digital subtraction angiography, which provides excellent spatial resolution. And of course, you can then angle the plane of the image acquisition relative to the trajectory of the aneurysm clip, for example, and evaluate that nicely. But instead, we decided we wanted to see what CT could do, and especially in the context of dual energy CT and model-based iterative reconstruction. So in this case, what we did is we used a reader study to compare image quality using filtered back projection, which is kind of the standard CT method, and this model-based iterative reconstruction. And we built a phantom, and this is essentially what our phantom looked like. We used, we had two aneurysm coils and two aneurysm clips, and we built a makeshift arterial system. As you can see here, we inserted contrast at the same, actually we measured the Hounsfield units of the contrast in this and diluted it to the appropriate contrast that we measure on a CTA. And we placed these aneurysm clips and coils. I don't know if you can see them, but here, for example, is a coil mass, and then there's an aneurysm clip right here, and then there's another one here near the paraclinoid distribution. And then we literally scanned this cadaveric, you know, phantom for 3 hours and varied just about every parameter that we could in the CT scanner, because we were trying to find out what the best way to evaluate this, you know, to come up with a solution. So this is, I'm just going to give you just an example of some of the parameters that we looked at. This is just within the model-based iterative reconstruction arm. I'm not going to go into the dual energy CT arm. But this was, so we did quite a lot of scanning parameters. The key thing is that we showed it to two neuroradiologists and asked them to score the evaluation of the vessel itself, the vessel lumen, the coil, the clip, and see what they thought, which was better, the filtered back projection or the model-based iterative reconstruction. And consistently, they picked this, the model-based iterative reconstruction. This is for the coils, and you can see that coils result in quite a lot of streak artifact. And I wouldn't say that this is totally mitigated, by the way, by using model-based iterative reconstruction. In fact, if this beam hardening artifact had projected into the lumen, I think it would have been pretty problematic. But unfortunately, the way we constructed this, these are the results that we obtained. Here we see a clip, and in this case, the clips tended to do much better than the coils, but certainly the model-based iterative reconstruction was preferred. And then same thing here with the coil mass. Again, the way the auger gel that we used just solidified in the way, and unfortunately our phantom didn't project in the direction that we would have liked. But nonetheless, our readers tended to prefer this. And so now, more importantly, I wanted to mention this new scanner that we have at Harborview, and this is something that I think is going to reach, or at least there's going to be a lot of national attention in this, because I think dual energy CT is finally at a point now where it's able to offer some significant advantages. In this case here, for example, we can see that the higher spatial resolution on the top row, these are coronary stents that are evaluated, multiple different types of coronary stents. This is from a publication recently. You can see this is the filtered back projection in the upper row, and then this is the essentially multiplanar formats using a dual energy technique. And you can really get a much better idea of what the stent prongs, for example, or essentially and also the contents, or the intraluminal portion within the stent. And so certainly looking for in-stent stenosis, this would probably be better performed with dual energy CT. This remains to be tested in humans. One of the nice things that the dual energy technique allows is something called, well, essentially allows us to look at metal artifact suppression. I wouldn't say it's a different modes that you can use with this technique, and we can certainly reduce a lot of the streak artifact that we see surrounding these two metal devices here. Of course, it's not eliminated, and information that wasn't obtained, as I'm illustrating here, information that was not obtained can't be created, but it certainly reduces a lot of that artifact, and this is something that we've started using in our spines as well as brain scans. This is something that might be important for you guys. This is the ability to evaluate for brain hemorrhage. And this is, I should mention, this is a contrast exam here. And this is the raw data map that's constructed from this. And this is basically an iodine map. And more importantly is that you can see that within this intracranial hemorrhage here, there's a small focus of active extravasation. I don't know if that projects well here where that blue arrow is highlighting. And so we can detect active extravasation here just by using an iodine map or identifying, using base pair subtraction, the iodine versus the hemorrhage. And so that is a nice benefit. Otherwise, before we were trying to window and level into these findings, and that made that difficult. And I think I sent this around to a few of you, that this is essentially a, well, let me ask you this. What do you guys think? What was the technique used to generate this? I know some of you probably saw these images. Well, I was pretty excited about these images. I sent them around to several of my neuroradiology colleagues across the country, and actually one of them wrote back and said, wow, I can't tell you how excited I was when I saw these images. I can't remember the last time I saw an MRA look this good. And of course, this is actually a CTA that was done. And what's nice about this is that what was done for the processing is simply bone removal. So this was using this dual energy technique to remove all the calcium from the image using base pair subtraction. And then this is simply a MIP that we generated, and I windowed and leveled this to make it to essentially approach that of an MRA. And then this is this sequence I showed you before, where this is the ASL with the look locker readout. And I think you can see that, you know, certainly the CT looks pretty good in terms of, you know, the overall quality for a fully automated system. This is a case that we had actually yesterday, and I just processed this. This is essentially an aneurysm off the supraclinoid segment here, and I'm starting to question whether or not we really need to obtain diagnostic cerebral angiograms in some of these patients when we can do reconstructions like this. Certainly for treatment, that would be essential, but I think it's a matter of time before we're able to obviate the need for DSAs in some of these patients. Okay, one of the last things I want to talk about is the 5-minute MRI, and I say almost because we're not quite there, and this is actually work that's coming out of Jim Pipe's lab at the Barrow Institute. And I think the last time I talked to him, he's able to obtain 7 sequences in MR in 6 minutes. So he's almost at 5 minutes. And you'd say, how is this done? And when I heard about this, I actually went to visit him in his lab. And he showed me this equation. And I think of this as like the Schrodinger equation of MR. But I think the key thing is that he rearranged some terms. And he said, OK, basically, if we consider SNR, signal-to-noise ratio, then we've got all these terms here. And you know, he basically pretty quickly eliminated most of them, but I think 4 or 5 of them. And then the key thing is what is a good SNR to look at? What do we like to look at? What do you guys think is diagnostic quality? I had no idea. He said, well, let me show you. And so he showed me an SNR of 2, and I realized right away that that was a horrible looking image, and there's no way I could interpret that as a diagnostic radiologist. But when we got to an SNR of 20, that was really where I was pretty happy. And so I'm going to show you some of the images that he's able to obtain. And I think the physics behind it is it's certainly important and is critical, and I think it's the limiting factor right now. But the key thing that he's using to do this is basically a different case-based trajectory, and I'm not going to burden you guys with the physics here, but I just want you to realize that I think that this is certainly coming down the pipeline, and I'm pretty excited about it because I think the ability to obtain diagnostic imaging in a 5-minute exam on MR is going to really change the way we think about MRI. So what they're doing is essentially a spiral readout of case-space. So before we would read out case-space in a Cartesian trajectory, essentially we go back and forth through lines of case-space. The difference here is that this is essentially a spiral. It turns out that these images that I'm showing you here are based on the golden mean ratio, essentially. It's a trajectory, a logarithmic trajectory through case-space. And this is more efficient on the scanner because it uses the gradients more efficiently, and it's also faster. There are some challenges with this technique, and it remains to be seen if this will actually replace a lot of what we currently do. But I certainly am somewhat excited about this. So I just wanted to show you, these are some of the images that were done, and I'm not sure how well they project, but this is essentially using these different trajectories. One of them is done with this spherical trajectory, the other one is a cylindrical trajectory here. The important thing, I think, here is that this is the conventional MRI sequence, and then these two are different possible solutions with the spherical K-space trajectory. I know that this is relatively small, and I apologize for that, but you know, this was already in the literature, meaning that what's currently available is even slightly improved compared to this. These are some of these images magnified, where you can see that this is essentially the different techniques, and then this is the one of these spiral techniques. And so you can see that that our SNR actually appears to be pretty good. This is actually a map of SNR and within the sequence, and this is compared to basically a turbo spin echo technique. And then finally, this is the Cartesian imaging done here, and then this is a 3D Cartesian, and it's a 2D Cartesian at the top, and then of course a spiral readout here. And I think they're starting to look pretty good. You know, there's a little bit of blurring, but again, I think that images that I saw that he was able to generate looks pretty good. And then at the bottom here, I just wanted to show you what these images look like. Again, with the spiral, the 3D Cartesian, and then the 2D Cartesian trajectories here. Okay. Last thing I want to finish with is something called demodulation. And this is a work that Mike Hoff in the Department of Radiology brought to us, and we started working on this right away. I thought this was pretty exciting. It turns out that in the context of what we just mentioned with spiral readouts, where it's a little bit more efficient, this technique called BSSFP, or balanced steady state free precession, is actually a pretty efficient sequence and technique. It's efficient with high signal to noise ratio. You guys might have seen this at Harborview as the KISS, or the CIS sequences, CISS. Here with Philips, it's known as BFFE. Anyway, it's useful for fluid and tissue differentiation. And in his work, in his PhD thesis, he developed a way to actually get rid of a lot of these artifacts that we see in this technique. And we stumbled on this almost accidentally when we started working on this project here. And you know, generally there's field inhomogeneity that induces signal modulation and/or banding, and that has been something that's handicapped this particular technique. We use this a lot for imaging of the trigeminal nerves, and so I just wanted to mention this as one possible solution. More recently, we've noticed that this can be used in evaluating or essentially eliminating physiologic motion. And while that isn't a problem yet, we wonder at what point might this be a problem. And so you can see here, this is this pulsation artifact that you can see through the imaging plane here that gets eliminated with this particular technique. And more importantly, we notice that this technique seems to mitigate motion or CSF pulsation that we often find troubling or difficult to evaluate in the cervical spine. So this is, so how does this work? I'll just show you. This is a water phantom with a Lego model, and this is a hip implant. And of course, this is what this BFFE looks like in its native state. And then this is essentially the cervical spine, what the BFFE technique looks like. And this is what this looks like as a corrected sequence. And the same thing here, where we're able to do the same correction in vivo in human subjects. And I mention this only because I think, you know, we're pretty excited about the possibility of replacing CT myelography with this technique, where we can just put the patient in the MR scanner instead of doing an invasive procedure and injecting contrast into their fecal sac. I'll skip this slide here. So these are some of the examples of this demodulation, this banding that's occurred as signal pileup, and we can essentially eliminate this. And again, just going through, this is one of the 4 original BSSFP images. This is using what was traditionally the proposed solution before the complex sum, and then this is essentially the Mike Hoff's solution. Here's a couple other examples. This is one in which basically the knee, a hip implant is placed close by, and you can see that with this technique, those bands are eliminated. And the way this is done, without going through the detail, basically it's done by incorporating these 4 original images that are acquired. We can find what's essentially a complex sum, or a solution where on an ellipse where the imaginary and essentially real numbers coincide, and that allows us to eliminate some of these bands. So these are the raw data that was obtained here, and then of course this is the complex sum and basically the geometric solution. And then this is where we've obtained the geometric solution and in comparison to somebody with a T2 FSE. And I just want to mention two things. One is that this T2 FSE is one that was taken directly off PACS, and when images are sent to PACS, there's a lot of processing that occurs, or essentially image optimization, so it makes it look, or I should say image beautification that occurs. And this BSSFP solution, this geometric solution here, has not had that image beautification applied, and so if it looks pixelated, that's the reason why. So we haven't done image interpolation like what was done here. But I think you can see that there's at least some of this artifacts. Question of how will they project? Those artifacts are eliminated with this particular technique. And as I mentioned, most recently we were able to eliminate some of these the pulsation artifacts from both CSF, but also from vessels. Okay, I think I'll just end this here at this point. I want to thank several collaborators. This is just a few in prior projects, but there's several people that prior mentors as well as colleagues both here within the neurology department as well as other departments here on campus. And I hope that provides a relatively quick overview of some things that at least I'm excited about, both MR and CT, ways that we're trying to change the way we currently practice medicine. And thank you guys very much for your attention. Yeah.
We're talking about utility of trying to get your severe emotion down to mild, moderate, and these sorts of things. And from a clinical point of view, when we refer a patient, do you have suggestions about what you think about sedation? I can see where sometimes that might make things worse instead of better.
I recently had to do my sedation training. So the question is how should the referring doctors consider the patient disposition and/or how likely they are to remain still in the scanner when they're considering sending the patient to MR and whether or not sedation is needed. So having recently completed my moderate sedation training, I was reminded, of course, during one of these scenarios that you can oversedate somebody to the point where they become less able to comply and they become even more agitated, they move even more. I think that's certainly a consideration. I think if you know that the patient's less likely to move, that's obviously a good thing. We've already tried using, for example, inflatable pads that can try and kind of essentially wedge the patient in the scanner. We don't like to do this, but it's in an attempt to control motion. They work fairly well some of the time, but not all the time. In this research project that I've been working on with vasospasm, we're taking very sick patients who are very likely to move. And even though we inflate these pads to a relative degree of comfort, because we don't want to hurt the patients, we see them kicking their legs in the scanner, and we know that the head is, they're moving about as still. And I can tell you on the images that they look like they're moving. So I think that, yes, I would definitely advocate if you know the patient's not going to cooperate, that you should either image them later at a different time point or certainly consider sedation. That would be one solution. But it's not, I don't think it's a simple answer yet. I mean, this is an ongoing research we've continued because we've identified this problem. We're now started to look at other ways of solving the problem. But like I said, interestingly, we thought that maybe anatomy might have something to do with it, or I think that was an unknown question. And just from our small sample, it looks like that the patient disposition is the more likely cause. But even our outpatients, in 7.5% of them had moderate to severe motion. So even those who we think are walkie-talkies and able to interpret, commands and follow commands, they just simply don't do it all the time.
Well, I'll ask a question simply because there's comfortable silence. There's been a lot of interest recently in the idea that brain extracellular space depends on the alertness state. People who are asleep have an expanded brain extracellular space by perhaps 60%. This is good work done by a top flight scientist in animals, and a few bits of human data seem to support it. We make no distinction between awake and asleep patients when we image them, and yet we're moving towards such sophisticated technology. So I begin to wonder whether there might be some signal differences depending on that state. Have you followed this literature? Do you have any ideas whether that might be something that could be determined?
I have not followed the literature. I wish I had, but I don't have a specific answer in mind to that. The question was, I guess let me try and paraphrase this. Is there a difference in volume, essentially brain volume or extracellular CSF space in patients awake versus those who are asleep? I have not followed the literature, and I certainly think there are ways to image that space. It would be interesting to see if that's true. I noticed that there's several patterns that I've noticed in evaluating patients, specifically on MRI, depending on the age group, and I think it would be fascinating to look at that. Just something that I can talk in more detail later. But the balance in CSF spaces in the extraaxial compartment versus the ventricles, for example, is a really interesting mix. But I think it would take more I guess, kind of a cine type imaging where you're looking at that pulsation or the pulsatility or essentially CSF flow and altered CSF flow dynamics, I think is what we tend to think about. I know one of our fellows, for example, this year came from a place where they did do quite a lot of that imaging. But we haven't had a chance to look at that here. Yeah.
Thank you very
Yeah,
much. That was
thank you.
great.
Thanks.